Welcome to the weekly Neurology Deep Dive. Our goal here is simple. Take the source material you provide us, dig into it, and pull out the key knowledge and insights for you.
Exactly. And just a reminder for everyone listening, this is purely for education. There's no commercial goal here. It's really just a summary of the material provided. We definitely recommend reading the full published paper for the complete picture.
Right. So today, we're looking at the final results from the Champion-MG open-label extension study. That's the one focusing on Ravulizumab for adults with ACR antibody-positive generalized myasthenia gravis.
Yes, and this source is important because it gives us that long-term efficacy and safety data for Ravulizumab. Ravulizumab is an anti-complement C5 monoclonal antibody. So we'll really unpack the data, the trial design, maybe highlight some practical points for clinical practice.
Okay, let's start with the study design itself. How was this Champion-MG study set up, especially this long-term part?
Well, it started as a phase 3 trial, which had a 26-week randomized controlled period, the RCP. Patients who finished that could then choose to enter this open-label extension, the OLE.
Open label meaning they knew they were getting Ravulizumab.
Correct. In the OLE, they could receive Ravulizumab for, well, up to 4 years. But an interesting point is that even though the treatment itself was open label, the patients and the study staff actually stayed blinded to what treatment they originally got back in the randomized part.
Ah, okay. And the patients who were eligible, what are the key things a neurologist should know about who was included or excluded?
So they enrolled adults, 18 and over, with a confirmed diagnosis of anti-acetylcholine receptor, antibody-positive generalized MG for at least 6 months before screening.
Okay.
And severity-wise, they needed to be MGFA class 2 to IV at screening. So that's, generalized weakness ranging from mild up to significant, but definitely beyond just ocular symptoms. Plus, their MG-ADL score, that activities of daily living measure, had to be 6 or higher, both at screening and randomization, so showing some real functional impact.
What about exclusions? Anything particularly relevant there?
Yes, a few key ones. Patients couldn't have received recent IVIG or plasma exchange, specifically within the 4 weeks prior. Also, no rituximab in the past 6 months, and importantly, no previous treatment with any complement inhibitor like eculizumab.
Right, that makes sense.
And critically, vaccination against Neisseria meningitis was required within 3 years before starting the drug. That's standard procedure with these C5 inhibitors due to the infection risk.
Got it. So looking at the group that actually entered the OLE, I think the paper said 161 patients. What were their baseline characteristics like?
Yeah, so for those 161 patients in the OLE analysis set, the mean age was about 56 years old. Just over half, around 51%, were female. Race-wise, about 73% were white.
And their MG severity?
In terms of MGFA class at the start of the OLE, roughly 44% were class I and or B, so mild or generalized. About 50% were class I or B, moderate generalized, and then a smaller group, about 6%, were class I or B, more severe. Their average baseline MG-ADL score was 9.0. And the QMG, the quantitative myasthenia gravis score, that baseline average was 14.5.
And how is the Ravulizumab actually administered during this long OLE phase?
It was given intravenously every 8 weeks. The dose was weight-based, following an initial loading dose. Patients could continue stable doses of their existing cholinesterase inhibitors or immunosuppressants.
Could those other meds be adjusted?
Yes, investigators were allowed to change the doses of those concomitant meds during the OLE if they felt it was necessary. And rescue therapy, things like high-dose steroids, IVIG, plasma exchange that was permitted if a patient had clinical worsening.
Right. Let's move into the efficacy results then. Over these, potentially several years, did the improvements hold up? What did the long-term data show?
It really did. The data showed quite durable and sustained improvements in both the MG-ADL and the QMG scores. If you look at the group that got Ravulizumab right from the start in the RCP and continued it in the OLE.
A Ravulizumab group.
Exactly. Their MG-ADL scores by week 164 showed a least squares mean change from their original RCP baseline of minus 4.0 points. So that was highly significant. P-value less than 0.0001.
So a clear sustained benefit for those on continuous treatment. What about those who switched from placebo?
They also did very well. So the placebo Ravulizumab group, they showed rapid improvement once they started Ravulizumab in the OLE. After 138 weeks on the drug, their mean change from the OLE baseline was minus 2.1 points. Also significant, P equals 0.0005. And if you look at their improvement from their original RCP baseline, all the way out to week 164, which includes those 138 weeks of treatment, that change was minus 3.6 points. Again, highly significant, P less than 0.0001.
Okay, so significant improvements in daily function. What about the objective muscle strength, the QMG scores? Did they mirror that?
Yes, very similar findings. The continuous Ravulizumab group, their QMG score, improved by about 4.3 points from the original baseline at week 164. Again, highly significant, p less than 0.00001.
And the switchers?
The placebo Ravulizumab group, their QMG change from the OLE baseline after 138 weeks of treatment was minus 3.0 points, significant with a p-value of 0.0000. And their change from the original RCP baseline out to week 164 was about minus 3.7 points, also highly significant, p less than 0.0001.
Those average changes are impressive. But what about individual patient responses? Like what percentage actually felt a meaningful difference or even got to having minimal symptoms?
That's a great question, and the data here is quite compelling. Looking at MG-ADL responders, this was among 160 patients in the analysis, a very high percentage. 88.1% achieved what's considered a minimal clinically important difference, which is at least a 2-point improvement from baseline at some point.
Wow, nearly 9 out of 10.
Yes, and 80% achieved an even greater improvement, 3 points or more. But perhaps even more striking is the minimal symptom expression, or MSE. That's defined as an MG-ADL score of 0 or 1.
So basically feeling almost normal.
Pretty much, yeah. Very few or no symptoms impacting daily life. Among those who achieved that minimal 2-point improvement, about 42% actually reached this MSE state.
Okay.
And importantly, that state was often sustained. Of those who hit MSE, over half, 54.2%, maintained it for more than 50% of their remaining time in the study. And about a third, 33.9%, sustained it for over 75% of their remaining time.
So it wasn't just a fleeting improvement for many.
Exactly. It's worth noting, the paper mentioned that patients who achieved MSE tended to have slightly lower baseline MG-ADL scores to begin with, a median of 8.0 versus 9.0 for those who didn't, and that difference was statistically significant.
So the takeaway seems to be a high chance of meaningful improvement, and for a good chunk of responders, the potential to reach and maintain a state of very minimal symptoms.
That's right. And the source also mentioned that similar sustained improvements were seen in quality of life scores, like the MG-QOL-15-R and a fatigue measure.
Now, something really practical for neurologists managing MG is corticosteroid use. It's often a necessary evil, but we're always looking to minimize it. Did ravulizumab help with that in the long term here?
Yes, this is a really key practical finding from the OLE data. At the start of the extension, 112 patients were taking oral or enteral steroids.
Okay.
And over the course of the OLE, there was a clear reduction. Among those patients on steroids, the mean daily dose dropped significantly. It went from 17.5 milligrams per day at the OLE start down to 11.7 milligrams per day at the last reported dose. That's roughly a 33% decrease in the average daily dose.
A third less steroid on average, that's substantial.
It is, and you can see it in the proportions too. The percentage of patients taking more than 10 milligrams a day fell from about 58% down to just over 37%.
Okay.
Conversely, the proportion taking 10 milligrams or less increased from about 42% up to nearly 63%. And even more encouraging, the proportion on a very low dose, 5 milligrams or less, basically tripled. It went from just under 10% up to 31%.
And did anyone get off steroids completely?
Yes, about 12%, specifically 12.4% or 14 patients out of that group, had completely discontinued corticosteroids by their last assessment in the OLE.
That's really significant data for practice. We know all about the long-term problems with steroids, the bone issues, diabetes risk, weight gain, mood changes, infections, you name it. Being able to substantially lower the dose or even stop it aligns perfectly with treatment goals and guidelines aiming for steroid-sparing approaches. It really impacts overall health.
Absolutely. And another related outcome they looked at was the rate of clinical deterioration events. These are things like an MG crisis or a significant worsening that needs rescue therapy, basically times when the patient's health is in jeopardy because of the MG.
How did ravulizumab fare on that front?
The reduction was quite dramatic. They looked at event rates per 100 patient years. So in the year before the study started, the rate was 44 events per 100 patient years based on patient recall and records. During the randomized period for patients on placebo, that rate was 60.4 events per 100 patient years. But for patients on ravulizumab, across both the RCP and the OLE combined, the rate plummeted to 12.6 events per 100 patient years.
Wow, that's a huge drop.
It really is. It translates to about a 71% reduction compared to the year before the study, and almost an 80% reduction, 79.1% to be precise, compared to placebo during the randomized phase. Both were highly statistically significant, p less than 0.00001. And they noted very few actual MG crises occurred during the OLE. It really suggests the treatment helped stabilize the disease.
Okay. Efficacy looks good, steroid-sparing effect is clear, reduction in deteriorations. Let's talk about safety over this extended period. What did we learn there?
Sure. The safety analysis covered all 169 patients who received ravulizumab at any point. As you might expect in a long study, most patients, about 96%, had at least one treatment-emergent adverse event.
Yeah.
But the vast majority were mild, grade 1, or moderate, grade 2.
Were many related to the drug itself?
Adverse events considered related to ravulizumab occurred in about 41% of patients. The most common things reported overall happening in 15% or more were COVID-19, which isn't surprising given the time frame, headache, and diarrhea.
What about serious adverse events?
Okay, so any serious adverse event, or SAE, occurred in about 39% of patients over the study duration. But SAEs specifically considered related to ravulizumab were much less common, around 6.5% of patients.
Do we know what those were?
The paper listed some examples. Several were infections like pyelonephritis, E. coli bacteremia, UTI, pneumonia, gonococcal infection, cellulitis, erysipelas, and gonorrhea bacteremia. So pancreatitis, mitral valve stenosis, dysphagia, suppurative tendinitis, worsening MG symptoms, and one case of non-meningococcal meningitis.
Okay. Any deaths reported?
There were 8 deaths during this study, 2 in the RCP and 6 in the OLE. Importantly, none were considered related to ravulizumab treatment by the investigators. The causes listed included COVID-19 for 4 patients, drug toxicity attributed to combined effects of other medications, dehydration, 1 unknown cause, and 1 cerebral hemorrhage.
And the big one with complement inhibitors, meningococcal infections.
Critically, no cases of meningococcal infection were reported in this entire study, including the OLE. As mentioned, there was that one case of meningitis where the cause wasn't identified, but cultures were negative for Neisseria meningitis and other common bacteria.
So summing up the safety, it sounds like it was pretty much consistent with what's known about ravulizumab and this class of drugs, with no new major alarms ringing after extended exposure.
That's exactly right. The safety profile held steady, consistent with previous reports. No new safety concerns popped up over the long term. And routine monitoring like labs, vital signs, ECGs didn't show any clinically important changes either.
Of course, no study is perfect. Did the paper mention any specific limitations we should keep in mind?
Yes, they did briefly touch on a few. The main one is inherent to the design. The OLE phase didn't have a concurrent placebo group, which is typical for extensions, but it means long-term comparisons are sort of historical or based on the earlier RCP.
Okay.
They also noted that because of the COVID-19 pandemic, they sometimes had to do QMG assessments over the phone, which might have introduced some variability there. And finally, they pointed out that patients who needed rescue treatment were still included in the main efficacy analyses, which they suggest could potentially slightly underestimate the true treatment effect if those patients were analyzed differently.
Right. Important context. Okay, let's try to synthesize this. For you, the neurologist listening, managing patients with AChR-positive GMG, what are the core takeaways from this Champion MG OLE data deep dive?
I think the primary message is about clinically meaningful and durable efficacy. This study really demonstrates that ravulizumab provides sustained improvements in both daily function, the MG-ADL, and muscle strength, the QMG, for these patients over the long haul up to 4 years.
And the high response rates.
Exactly. The high responder rates, plus that significant proportion of patients achieving and sustaining minimal symptom expression, underscores its potential to really lessen the disease burden substantially.
And from a practical management standpoint.
2 key things, I'd say. First, the strong evidence for a steroid-sparing effect. Seeing those average doses drop by 1/3, seeing more patients get to low doses or off steroids completely clear, that's hugely valuable given the risks of chronic steroids. Second, the reassuring long-term safety profile. It remained consistent, no new major issues emerged, and importantly, no meningococcal infections in this particular study.
Okay, so as we wrap up, here's a final thought, something drawn from the source material for you to ponder. We saw really good results, lots of improvement, many reaching minimal to symptoms, but not everyone got to that minimal symptom state. And this raises a question the authors implicitly pose. For those who don't achieve MSE, might there be a role for adding other treatments, perhaps therapies with different mechanisms of action on top of complement inhibition? Something to consider in complex cases.
And again, we hope this summary was helpful, but please do go and read the full published paper. It contains all the detailed data and nuances we couldn't cover here.
Absolutely. Thank you for providing the source material that allowed us to do this deep dive today.